I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about pleasure and orgasms and all that great stuff. Before I get into it, a few things I want to make very clear. I am definitely not giving any type of medical advice. If you have any questions about your sexual health, make sure you go see your healthcare provider. And if you have any questions about your religion, make sure you go speak to your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I am so excited to have on with me today Dr. Komisaruk. And Dr. Komisaruk is the OG of talking about orgasms, learning about orgasm. He knows everything that you would want to know about orgasms. So
I don't know about that.
Yeah, no, you are truly amazing. So I'm just so excited to have you on with me. And so, Dr. Komisaruk, could you please introduce yourself to the viewers in the audience out there who may not know who you are?
Oh, well, I am a professor at Rutgers University. My specialty is behavioral neuroscience. I've been involved in research for reproductive behavior and reproductive physiology, starting with laboratory animals, and then most recently, for the past several decades, in humans. So I do both animal and human research, depending on what the problem is, what the question is. And I do brain imaging of sexual response in women and men, and including orgasm, to find out what parts of the brain are involved and how they might possibly produce pleasure of orgasm.
Amazing. So you've spent decades researching the neuroscience of orgasm. What drew you to this study?
Well, it didn't start out that way because when I did my doctorate, my doctoral research, I was implanting hormones, crystals of hormone in the brain, and inducing behavior in natural behavior in laboratory animals, and and then I was interested in what are the hormones doing to the neurons to produce the behavior? How are they stimulating the behavior? And this was sexual behavior. And so for I did my doctoral dissertation at my doctoral research at Rutgers University, and then I did the only person who was studying how hormones influence neurons was Charles Sawyer at UCLA in the Brain Research Institute. So I did my postdoc with him, my postdoctoral research with him. And when you go into a new laboratory, you work on a project that is ongoing just to get into the groove. So he was studying a reflex called the neuroendocrine reflex, in which the mating stimulus produces the mating stimulus in rats. This is demonstrated in rats, that when female rats mate, the mating stimulus activates the hormones of pregnancy. And so he was studying what happens in the brain under these circumstances. And of course, in doing this kind of research, it has to be under you do a situation under anesthesia to record the activity of the neurons. This was before live awake animal recordings were possible. This was a long time ago. This was in 1965, so that was about 60 years ago.
Yeah.
So I've been doing this for a while. I started when I was young, and so it had been demonstrated that there's artificial vaginal stimulation could do the same thing in an experimental situation. That vaginal stimulation with a glass rod could also in female in rats uh, that would also stimulate the hormones of pregnancy. And that's what he was studying. He was recording the activity of neurons in the brain that responded to the vaginal stimulation and correlating it with the hormones released by the pituitary gland in response to that. It was at the time there was it was great interest in how the brain controls the hormones. And there's a link that the pituitary gland is actually attached to the brain, and there are several mechanisms by which sensory stimulation, which gets to the brain, can then be transformed into hormone release by the pituitary gland. And the pituitary gland is the master gland that controls the ovaries and the testes. So that was there was a lot of interest in that, how the brain can control the hormones and how the hormones then control the brain. Uh, and it's an area called neuroendocrinology. Um, so that's how I got involved with that, of looking at the recording brain activity during vaginal stimulation in rats. And I continued doing that, and when I came back to my laboratory at Rutgers University, I was hired back onto the faculty after my postdoc. So I started repeating that work, and but now there was a method for doing the recording in wake animals. So I started doing the recording in wake animals, and I found that when I applied the vaginal stimulation in the wake animals, they suddenly became immobilized, and they went into the mating stance. It's called the lordosis posture, where they elevate the rump and they elevate the head, and and they stand still, and that facilitates mating. But the male can mount if the female is standing still and exposing her genital region. So I noticed that, but then also I realized that with the vaginal stimulation, now the rats didn't move. In fact, I could push against the cervix of the rat with the glass rod, and they would just slide along the table without walking away. They were free to walk away from the probe, but I'm just pushing them forward, and they're stiff-legged. And I said, that's really strange, because what happens if I would pinch a foot? And so normally you pinch a foot on the rat, and it pulls the leg away. During the vaginal stimulation, they didn't respond at all. They didn't pull the leg away. They didn't squeak. Nothing. Um, so I did some brain recording and showed that the pain is blocked. The neurons in the sensory regions of the brain that normally respond to painful stimulation, like pinching a foot. When I did the vaginal stimulation, it just blocked their response. The neurons didn't respond. The rats didn't respond. So I said, the only scientific way I'm going to know whether pain is really being blocked by the vaginal stimulation is by asking women. All the fancy equipment I had, the only way you can really know for sure if pain is blocked is by asking somebody. There's no way of recording to prove doing any brain recording to prove that somebody feels pain or the pain is blocked. It really depends. It's a subjective experience, and the only way of proving it is by asking somebody, despite all the fancy equipment. So I decided that was going to be something I had to do. And then fortunately, my colleague, fortunately, I got an email. The chance, life is full of chance occurrences. So I was at that point. I said, well, someday, I'm going to have to do this. I'm going to have to. It would be interesting to know what happens in women. So I get this email from Beverly Whipple who I had heard about, had just published this book called The G Spot, and she said that she had heard about my research in blocking pain with vaginal stimulation, and she wanted to know some more about it. Uh, and I thought, I said, well, I was giving a course in human sexuality, and I found out that she was in South Jersey. Newark is in Central Jersey, and Beverly Whipple, who had just published the G Spot, was in South Jersey on the faculty. She was a nurse on the faculty of in South of Gloucester County College in South Jersey, in the nursing department. So I invited her to give a seminar in my course, and so she came to Newark. With She was scared to come to Newark, but she had a bodyguard. She came with a
Oh,
bodyguard,
wow.
and so she gave a very nice seminar to the class, and then we went out to dinner after. Everybody went out to dinner after, and she said that uh, she's been doing. She was doing this. She came up with the G Spot because she was doing. She was teaching women to use Kegel exercises to control incontinence. Stress urinary incontinence. Um, and doing the Kegel exercise would block the expression of the urine, when they laugh or cough or something. So, and she said that she was doing that, and that's how she came up with. She realized that there's a very sensitive spot, and the women said it feels pleasurable. Uh, and she said, but that's not really. She didn't really know how to do research, and she wanted to know if she could, if I could, if I could show her teach her how to do research, scientific research. And I said, well, yeah. I mean, why don't you apply for the doctoral program in our department, the psychology department? And so she applied, and it was interesting because a lot of the faculty thought that she was already famous for the G Spot, and television celebrity and everything, and they were very suspicious that this would uh, somehow uh, disrupt the activities of the psychology department, and it would be bad publicity and all that. This sensationalism and all that. And actually, uh, but she applied, and she impressed everybody. She's very serious, a very serious uh, nurse. I mean, professional nurse. And so she was accepted into the program, to the doctoral program. And I said, look, why don't we see whether vaginal self stimulation blocks pain in women, and do that as your doctoral dissertation? And she said, okay. So that became, we set up, we got IRB approval, ethics, the university ethics panel, which that was a whole other story, because this was a very, very, to do vaginal, studying vaginal self stimulation. Um, it took them a while to
I'm sure.
come around to approve it. That's a whole other story that I don't want to.
Yeah.
And so how I finally got approval for it, but we got the approval, and then we started getting set up to do the study, and there was a delegation from the department of faculty who told the director, we don't want. Uh, this is we were actually, it was in the Institute of Animal Behavior, which is a world renowned uh, uh, institute at Rutgers, Newark, that was studying all kinds of different natural behavior in animals. And now, and I started out with animal research, so that's how I got involved in it. And so the delegation said, we don't want anybody doing human research in the Institute of Animal Behavior. It's going to give us a bad reputation. And the director said, Komisaruk has academic freedom. You can't stop him.
Oh, that's great.
So he supported me, and so we proceeded, and that's how we did the study. We measured pain thresholds by squeezing. Had a device that put pressure on a finger that increased the force gradually. We can calibrate the force, and while women did the vaginal self stimulation, we said, how much force does it take until you say it first hurts, and then we stop and we did the next finger. Uh, Without any stimulation, we got the baseline, and then when we had when the women started doing the self stimulation. By the way, Beverly was in the room with the women. We set up a laboratory room. She was in the room with the women. I was outside. I getting the report from her. Um, and so when the women were applying the vaginal self stimulation, it took more and more force as they were approaching orgasm from the stimulation. It took more and more force before they said it hurt.
Hmm.
But at the same time, we were measuring just the touch threshold. In other words, we're measuring pain threshold by how much force does it take until squeezing the finger until they say it hurts, as opposed to just using very fine fibers on the skin to see if they can detect touch. So the touch thresholds didn't change, but the pain thresholds went up. So in other words, we were getting by the vaginal stimulation was producing a selective blockage of pain, but not touch. So it wasn't that the women weren't distracted. I mean, they could pay attention and tell us that they could they how much force it took until they could feel it. That amount of force didn't change at all, and they were doing that every time we took a measurement of the pain thresholds. So we were getting a selective inhibition of pain, which is defined as analgesia, as opposed to anesthesia, because anesthesia is you don't feel touch, you don't feel pain. It's like Novocaine in the gums, or in the you don't feel anything. But analgesia is a specific blockage of pain, like aspirin produces a blockage of pain, headache, but it doesn't block touch. So, um, that was our finding, of a very surprising finding of uh, that vaginal self stimulation produces a very powerful pain blockage, and it was strongest at at orgasm. We got over 100% increase in pain threshold at orgasm. So then I wanted to know this is a relatively simple stimulus, and it's having a powerful pain blocking action. What's the nerve pathway? What nerve is carrying this pain blocking signal? I went back to the rats and I did surgery on the rats, and found that it's the pelvic nerve was the main nerve, the pelvic nerve that carries sensation from the vagina and the cervix. That's the main that produced the main pain blocking action. Um, and then I said, so is it the same thing in women? Uh, so in order to test different nerve pathways in the women, what I did was study women who had uh, severed spinal cord traumatically, patients who had severed spinal cord at different levels, because the different sensory nerves from the genitals enter the spinal cord at different levels. And my most severe the most severe condition was women who had the highest level of a severed spinal cord, because that would block there's a pudendal nerve, the hypogastric nerve, the pelvic nerve. They all go up. Uh, so uh, we could tell which nerve was blocked by which level, by looking at the levels of the injury that the women had. Um, and but the big surprise was that the women who had the severed spinal cord highest up, when they did the vaginal stimulation, they said they can feel the vaginal stimulation. They said when they had the spinal cord injury, the doctors told them they can't, forget your sex life. Your sex life was over. And they were that for the first time in like 10 years, because these are women who had, the traumatic injury years before. They said they never tried because they never tried the stimulation because the doctors told them forget it. And there was there was a lot of tears of joy. I mean, tears of very emotional reactions in the lab when these women were saying not only could they feel it, but they could have orgasms from the
Wow.
stimulation, and they couldn't believe it. And the we were collaborating with a spine specialist, a spinal cord specialist, an MD, uh, and she said this is impossible because if the spinal cord is severed and all those nerves are blocked, they can't possibly be having orgasms. They can't possibly feel it. And I said, well, we looked at the MRI of the spinal cord, and the spinal cord was severed. And she said, there's something wrong with the experiment,
Hmm.
and this is impossible. And I said, but here's the data. You see the women. You're talking to the women,
Yeah.
and we see what the level of the injury is. Uh, there's some weird something is strange, uh, and the doctor said this is impossible, and she quit the project
Oh my gosh.
because she said this is impossible. Something's wrong, and we don't know what's wrong. But I said, well, maybe there's another nerve pathway. Maybe it's the vagus nerve, which is a cranial nerve, and maybe it goes as far as the vagina and cervix. And there was actually just a couple of years before that, there was a publication in rats showing that in fact the vagus nerve does convey sensation from the vagina and cervix. And
Wow.
I said maybe it's the same thing true in women. And so I said, let's. The only way I'm gonna know if the vagus nerve is really carrying the sensation is if I do brain recording in the region of the brain that the vagus nerve projects and see if when they apply this vaginal stimulation, we activate that part of the brain. Uh, so that was a whole new story of how I got into brain imaging to solve this problem. And uh, a long story. One story is that I was able to get collaboration in the PET recording, the positron emission tomography center in North Carolina, Wake Forest
Oh.
University, a Baptist. It was a Baptist hospital, and we started doing the study, but then the director of the center said I have to stop because I'm going blind. He's a radiologist. I'm going blind, and I have to quit. And uh, a young guy, it was really very very tragic. Um, so he quit, and
Hmm.
the woman who came in said, "Look, this is a Baptist hospital. There's no way we're going to do a study of women doing self stimulation, self vaginal self stimulation." So again, another problem, and so that took fortunately, there was we had a seminar at Rutgers, and a woman from the dental school who was studying swallowing in people who had lung throat cancer. She was doing MRI of the brainstem, which is where the vagus nerve projects, and she was doing functional MRI. And I said, could we do this study at the medical school? So we got I got approval to do it at the medical school. So that's how we finally did functional MRI of the brainstem of the medulla where the vagus nerve projects, and we found in fact it's activated. So that supported the vagal sensory nucleus in the brainstem was activated in these women with the severed spinal cord who said they could have orgasms from the stimulation. So we got
Hmm.
activation there, but we also got activation of it. Now all of a sudden, I realized that we're seeing activation in the brain during orgasm, and nobody had reported that. Nobody ever reported where in the brain orgasm occurs in women.
Yeah.
So this was our first
It's
the first
amazing.
demonstration of where orgasm occurs in women. So that's how I got into it.
So where does it occur in women? in the brain?
Basically everywhere.
Okay.
Wait, really, really. I mean, I
Yeah.
can start enumerating the regions, but the point is that the phenomenon of orgasm is a whole brain phenomenon,
Wow.
a whole brain activation of the in the cortex, the thalamus, the hypothalamus, the cerebellum, the pons, the medulla, everything,
Everything. Everything. That's amazing.
everything gets activated,
Wow.
and it's really dramatic to see. Well, I have some images like that. I could prevent present. I could provide you with the images that you might want to insert with editing it. But um, which shows the overall activation. Uh, One of the interesting points, just incidentally, is that uh, what we're actually measuring with the functional MRI method is the increase in blood flow when neurons, in other words, when a group of neurons in the brain becomes active, they open up the blood vessels surrounding them, and that allows more blood to come in to those neurons, and it also increases the utilization of oxygen from the blood by those neurons. They're more active, so there's an increase in blood flow and oxygen utilization, which is very good for neurons. It brings nutrients and oxygen. So the fact that the whole brain gets activated means that orgasm is a great way of increasing the activation of the whole brain and increasing the nutrition and oxygenation of the brain. It's like great brain exercise.
Wow.
Just so, I mean, if you want to,
I said, if you want to stimulate the brain, I wonder, like, people with,
right.
like, let's say dementia or
Yeah,
things with,
that's exactly where I was going.
yeah.
You got it. That I don't know of any study that has uh, looked at whether um, orgasm can forestall Alzheimer's, but it can't be bad because I mean it's just turning on the whole brain, giving them exercise, giving all the neurons exercise
That's
everywhere.
amazing.
What could
Yeah.
be bad? What could be bad?
Absolutely nothing. I mean, that sounds phenomenal. I'd love to see if somebody ever does that research, right? That would be so amazing. So some people believe that there are different types of orgasm, clitoral, vaginal, cervical.
Yeah.
From a neurologic perspective,
Yeah.
are these actually different experiences, or is it just one whole
Uh,
body brain
I
experience?
what we and I could we did a study that I can show you those give you those data. Um, the What we did, we mapped uh, the response in the brain in the sensory cortex where the sensation is perceived of women doing clitoral self stimulation or vaginal stimulation or cervical self stimulation. Different. I had designed a stimulator that could do uh, each of those individually.
Mm,
And what we found was that each of those there was a slight difference between where which neurons are activated by clitoral stimulation or by vaginal or by cervical stimulation. They all go to the same general region. It's like a cluster of grapes
mhm.
that like the clitoris, vagina, and cervix is each a different grape, and they all cluster in the same part of the sensory cortex, which incidentally is the same part of the sensory cortex as in men, which we've also shown. Um, they all so they all activate different uh, groups of neurons, but they're all clustered together.
Mm.
And what that means, and we know that it's possible to stimulate an orgasm from clitoral stimulation or vaginal stimulation or cervical stimulation. Each of those is capable of eliciting orgasm. So what that means is that since each of those when we look at where the sensation projects in the sensory cortex, the fact that the clitoris and the vagina and the cervix all activate different groups of neurons in that whole region, and that each of those is capable of stimulating orgasm, that means if you stimulate all of them together, you're stimulating a much greater group
Mm,
of neurons.
yeah.
And women describe that when if they stimulate each of those all those regions concurrently, their orgasms are more intense than stimulating any one of those separately. They're more intense, more pleasurable, and it makes sense because it's a way of activating more and more neurons, each cluster of which is capable of inducing orgasm.
It's
And
amazing.
another interesting, surprising finding that we did was that we also were mapping other parts of the body when we mapping the clitoris, vagina, and cervix. We asked the women to apply nipple self stimulation. And what was surprising was that when they applied the nipple stimulation, uh, certainly it activated the chest area on the sensory map, but it also activated the same region that the genitals activated. In other words, the nipple stimulation is stimulating the same neurons as are stimulated by genital stimulation.
Wow. Yeah.
And that's, I mean, many women describe nipple stimulation as erotic. And maybe that's why, because it's activating the genital sensory neurons. So then that implies that adding nipple stimulation to the clitoral, vaginal, and cervical stimulation could intensify the orgasms even more.
Yeah, that sounds like that would just blow your mind, literally and figuratively.
Plus, uh, we found that there's a report that the vagus nerve carries sensation from the ear, the
Ah,
this region of the ear.
mm,
Uh, it's called the symbicontia. This uh, little part of the ear, and we did a study where we stimulated that part of the ear and recorded in the brain where the vagus nerve projects, and we got activation in the vagus nerve. So we showed that in fact ear stimulation will activate the vagus nerve, and we published that. And that means that if you add ear stimulation of this part of the ear to the other four regions, that could increase it even further.
yeah, that would like just maximize the orgasm like
That,
10x.
that
That's amazing.
I don't know. I don't know if that could be dangerous, but I don't think so. I think there's enough control in the brain that it wouldn't.
Yeah, yeah, you don't know. It could be dangerous. So what are some of the biggest myths about female orgasm that science has now debunked? That
Biggest
you've debunked?
The biggest myth. So well, I mean, I guess to answer your question, are are clitoral, vaginal, cervical orgasms different from each other? I think well, there's evidence in the literature that indeed they are. The quality of the orgasm, um, uh, the quality, the women describe. I mean, in the literature, women describe clitoral stimulation as localized to the external genital region, just localized to the pelvic region, whereas vaginal stimulation is deeper and more bodily inclusive, or it brings in the whole more of the whole body, not just localized. And cervical stimulation has been described as this kind of vague, uh, very cosmic. Uh, One woman described it as shower of stars, and
Mm,
others describe it as a cosmic experience. And that's interesting because the vagus nerve mainly carry sensation from the cervix.
Oh.
And we don't, it's a very, we don't really know, we have very little feedback from the internal organs, especially the cervix. And that's why, even though it can produce orgasm, it's not like we don't have, we haven't spent all our lives correlating, the eye hand coordination. Or we say when we touch a finger, we're getting sensory input from this finger and from this finger and from our eyes. We don't have that kind of correlation with cervical stimulation and the vagus. It's an internal nerve that carries sensation from the liver and the kidneys and all that. So we and from the heart. So we don't have that kind of correlation, and that may be why those orgasms are more vague and these cosmic, these more less concrete descriptions. So the answer, the short answer is yes. The qualities of orgasm stimulated by those different regions, since they each carry sensation from by different nerves, the qualities are different, but they can all blend together and feel much more complex and much more pleasurable when you add them all together.
Hmm.
The next question was, what's debunked? What aspects of orgasm are debunked?
Yeah, like what are the biggest myths about female orgasm that you have basically debunked?
Well, I mean, people talk about the orgasm reflex. It's not a reflex. The orgasm, it doesn't occur. You talk about reflex, like a leg reflex. You pinch the foot and you get a leg withdrawal. That's a reflex. That's called a spinal reflex. That's what a reflex is. Orgasm is not a reflex. Orgasm is a phenomenon that occurs throughout the brain, and it's a whole body. It's a whole body involvement. The physiology, there's increase in heart rate, increase in muscle tension throughout the body that feels pleasurable. That there's release of oxytocin into the bloodstream that produces uterine contractions, and the perception of uterine contractions. It's a whole body involvement, and lubrication. It's not a reflex. So that's one, to get rid of the idea that orgasm is a reflex. And another myth is that orgasm is only genital, but there's a lot of evidence in the literature, and Beverly and I published a paper on it, that there are many descriptions in the literature that it's possible to elicit orgasms from other parts of the body, many other parts of the body. They all seem to be the one thing that seems in common. I mean, people have described lip orgasms, nipple orgasm, breast orgasm, hand orgasm, basically any part of the body. And what the common element seems to be that stimulation of these different body parts can produce muscle tension, a buildup of muscle tension. And it's the buildup of muscle tension, the sensation of the muscle tension, which is it's our sense of our muscle contractions is called proprioception, meaning reception of sensation coming from the body proper, proprioception. And that is pleasurable. It feels good to stretch and to yawn, or to sneeze. It's the buildup of muscle tension and the release, and that is so. I've so there's plenty of evidence of non-genital orgasms. That paper is my most highly cited paper. For a podcaster, it probably doesn't sound like much, but that paper has gotten something like 45,000 reads.
That's amazing.
Well, I mean, but compared to your podcast, I'm sure it's nothing.
No,
But
it's not.
uh, so people are really interested in non-genital orgasms, and I think that's what the it's when you think of it feels good to be able to yawn and stretch, and it feels good to be able to sneeze uh, or to cough, even though it could be I mean it's associated with a cold and other unpleasant things, but uh, the actual performance of the movement, the buildup of the tension. Think of building up a sneeze and then the pleasure of releasing that tension. Uh, I've said that sneeze is an orgasm in the respiratory system, and
Wow.
actually, Dr. Ruth Westheimer, I told her that at a conference actually it was in Israel in 1982. No, 1980, something like that. And she used it in her radio broadcast after that. Um, but I think a yawn is the same kind of thing, and a stretch. You increase the muscle tension to a point, and then you relax it, and that buildup and relaxation is a non-genital orgasm. And so I think genital stimulation is unique in that it produces, like in the rat, the vaginal stimulation produced whole body immobilization.
Hmm.
So something about the genital stimulation has a very, very widespread action on the brain. I think maybe because there are a lot. I'm not sure that we don't understand that, but
Yeah.
it seems to have a very widespread and profound effect throughout the brain. Um, so uh, it's just doing what the muscle tension buildup and release does in many other contexts. It just does it really strongly, and
Yeah.
that's why it's so particularly pleasurable. But thinking of many other kinds of muscle tension buildup and release um, is I think that's the orgasmic process, and genital stimulation is a special case of the more general um, uh, orgasmic process.
With those non-genital orgasms, let's say that, I mean, I love that analogy of the sneeze. Do we get the same activation in the brain, or is that only with the genital orgasm that you see that full light up of the brain?
That's a really important question, but we have not. Nobody's been able to record the brain activity during a sneeze because the head movement is
Ah,
there's going to be too much head movement, and I had to solve the problem of head movement during orgasm by developing a very fancy thermoplastic mask where the thermoplastic is, you put it in hot water, you put the plastic in hot, it's a mesh, and
yeah.
you put it in hot water, and it gets very, very soft, and then you can mold it over it's a frame that
Oh, wow.
is used in radiology to keep the head still during an MRI scan in some cases for children. Uh, but so I used so you heat it up, put it on over the face, and mold it to the nose and the mouth and the eyes and everything, and then it in about a minute it cools and gets rigid. So I
Hmm.
did one of those on the front of each person, the front of the face and the back of the head, molded it to the back of the head, made a sandwich with these two things. And then I also got a neck brace that
Wow.
to hold the chin, to lift the chin and keep that rigid, and molded the F of the front and the back to the neck brace, and then bolted it down into the scanner. So
Oh
uh,
my God.
really get very, very. But people said it. I mean, I've done it myself.
Yeah,
they
yeah,
they don't mind it. It's comfortable, actually. They
yeah.
say it's interesting, an interesting experience to be bolted down. Um,
It's
uh,
another form of pink, it sounds like. I'm kidding.
uh, some offered to pay, but
Yeah,
I didn't say no, no, no. Um, so, but uh, that's how I did the orgasm studies.
wow.
That's how I'm doing them now. Uh, but so, but sneeze, that's really pushing it because it's a sudden movement. I mean, I get down to about 1.5 millimeters of head movement
Yeah,
with this with the mask, but a sneeze is really pushing it.
yeah,
But the idea, what you're saying, is a really interesting idea, because what about other kinds of non-genital orgasms um, that wouldn't be so severe? Could we generate those, and would there be some common region of the brain that to all of those? That's a really, really interesting question. Thank you for that idea.
yeah. You're welcome. Maybe I'll have to come to your, study and help you figure that out.
Well, well, you're welcome to do that. I have to figure out how to actually do that, but
Yeah,
it's a really, really good idea.
thanks. So many women struggle with orgasm or feel that something is wrong with them. And I'm sure you've heard women say all the time that, they've never experienced an orgasm. I've had patients say that in the office. And so, based on your research, how common is difficulty with orgasm?
Well, it's quite common, and
Yeah.
there are different types of orgasm problems. I've been working on this with Irwin Goldstein,
Yep.
um, and we've identified 6 different kinds of orgasm problems. Um, and an important consideration is that, and this is the basis for his starting to use specific kinds of drugs in different kinds of orgasm problems. Um, what I an interest what an implication of the fact that the of our finding that the vaginal stimulation blocks pain while the women are getting up to orgasm. So they're having an orgasm at the same time that their pain is blocked.
Hmm.
Now, what that means is that there's intense activation, excitation from talking about neuron activity. There's intense activation of neurons, and at the same time, there's intense inhibition of neurons that respond to pain. So, in other words, at going up to orgasm, there's a simultaneous. There are neurons that are getting more and more activated. More and more neurons are getting activated because ultimately the whole brain gets activated, and simultaneously, more and more neurons get inhibited. And uh, so that led me to the idea that the if you have excitation without inhibition, that's pain. If you have if you have excitation plus inhibition going simultaneously, then the inhibition can prevent the excitation from becoming painful, but it allows the excitation to get more and more intense without becoming painful.
Hmm.
So I developed this metaphor of a hot and cold water faucet that uh, that you can have a low turn on the hot water to a low flow, and that can be painful if the water is very hot. It can be painful, but painful like touching a stove or like getting a mosquito bite. Uh, and and you can turn on the cold water, and that will stop it from stop the hot water from being painful if they're both going at the same simultaneously. But then you can increase the hot water more, and it becomes painful again. But the flow is greater. There's more excitation. There's more neurons firing. Uh, and but if you increase the inhibition, the number of neurons inhibiting that, then it then it's okay. It's like the flow is greater. It's warm. It's not hot. It's not hot because you increase the flow of the cold water. So now it's still pleasantly warm, but at a much higher flow rate.
Hmm.
And you can keep doing that game of increasing the excitation, increasing the inhibition, and it gets more and more intense. So that is what I consider to be the model of orgasm, where the inhibition allows the excitation to increase uh, to a peak, and then the excitation becomes painful, and it turns the thing off because it becomes aversive at a high peak. So with that in mind, that is a guide to our understanding of how Irwin has uh, descriptions by women of different kinds of problems with orgasm. So, for example, one type is a woman said she starts a stimulation, and before she gets anywhere, it becomes painful, and she has to stop. So what I said was, well, it's because she doesn't have enough activation of inhibition. So what Irwin did, it's well known that SSRIs uh, have an inhibitory effect on orgasm. Uh, Selective serotonin, the antidepressants.
Yep.
Um, so I said, well, give a low dose of the SSRI and see if it enables her to increase the intensity without becoming painful.
Hmm.
So he did that,
Yeah.
and she said now she can have regular orgasms
It's amazing.
because she doesn't have to stop when it doesn't become painful. She can go all the way her old normal intense orgasms.
It's amazing.
So that's one type. There are also women who said the stimulation doesn't do anything for them. It just that they don't it doesn't get intense. So what he's trying is giving excitatory drugs, like recommending caffeine or other stimulants to see if this. We don't have any data on that yet, but I mean, this is the idea that based on the balance between the excitation and inhibition, um, that, for example, some women say they have uh, it takes them a long time, a very very long time, a delayed orgasm uh, to get to orgasm. They eventually get there, but it takes them too long. So that's another example of, I mean, a strategy of using excitatory drugs, caffeine or amphetamine. Um, these kind, trying different things. So it's really just it's there's an underlying hypothesis, but we're just at the beginning of trying different strategies. So there's insufficient inhibition in the first case. There's insufficient excitation in the second case, and then there's people who say they have the delayed orgasm. So he's trying excitatory drugs, and also drugs to try to prevent the inhibition. There's a type of women who have a little orgasm and doesn't get anywhere, and they have an orgasm, but it's a very low intensity, and then they have another orgasm, very low intensity. So they don't get any. There's no pleasure out of it. It's too low intensity. So again, he in that case he's trying both a stimulant and in stimulatory drugs and inhibitory drugs to see if it's possible to build up the excitation and the inhibition. So in other words, these are different types of orgasm problems that women have described clinically to Irwin, of it's too painful. They can't get there. It's too painful, or they get there and it's a very low intensity, or it's delayed, um, or they have an orgasm, but it doesn't feel good. They have a regular strong orgasm, but that's called an anhedonic orgasm. So they're having that bodily response um, to the genital stimulation, but there's no pleasure in it. And in that case, that might be a different kind of problem. That might be a cognitive problem of distraction, worrying about other things, or some kind of uh, cultural inhibitions, or that could be a very the anhedonic type of orgasm might be a cognitive issue where the body is responding, but the perception of it is uh, altered. That's the fifth type. Then the sixth type is women and also men. This is true of men as well. Each of these cases, uh, the post-orgasmic illness syndrome, which is
Yeah.
uh, where the women and men have normal orgasm, pleasurable orgasm, but as soon as they come off the orgasm, they feel like they're getting the flu, and they have this kind of flu-like symptoms that they describe of a malaise and headache and achiness and uh, brain fog. They describe, and that can last for hours or days, and it's very, very troublesome. Uh, and the one possibility is that there's some kind of immune reaction. So they're trying things like antihistamines that sometimes work, or other strategies. So we've identified 6 different types of orgasm that people have described the problems that they have. Um, the pain, or they can't get there, or they get there, but it's a very low intensity, or it takes forever, or they have this illness feeling afterwards. And we're trying different with the idea of excitation and inhibition combination. Uh, Thinking of this hot and cold water faucet combination of excitation and inhibition, which is a new idea because people tend to think of excitation as one. It's like a balance. It's either excitation is up and the inhibition is down, or the inhibition is up and the excitation is down. But the brain doesn't work like that. The brain has excitation and inhibition simultaneously. Um,
Yeah.
so we're dealing with that as a possible underlying mechanism for understanding different types of orgasm difficulties.
Yeah. So Barry, when you talk about orgasmic difficulties, this is assuming that these difficulties are at the level of the brain, right? Because if they were at the level of region 1, which is, the end organ, we would see that, right? Like if it's clitoral phimosis or something like that, that somebody has an issue with, and then like region 2, which is the, pelvic floor muscles, all
This is
that.
after all those issues are ruled out.
Got it. Got
We're
it. Yeah.
dealing with, I mean, of course, uh, Irwin takes an individual, individual person's problem, and then does socio-biological evaluation,
Biopsychosocial. Yeah.
biopsychosocial, cultural evaluation, and counseling, and then does the physical examination of the external genitals, of the pelvic floor, of what any possibility that it's a problem in the spinal canal, or the spinal cord, or the brain. And when those are any kinds of pathologies there are ruled out,
Yeah.
then we deal with the possibility that it's an issue in the brain
Yeah. Yeah.
with the excitation and inhibition idea. certainly uh, there are other causes of physical pathologies. For example, a herniated disc,
Yes.
a bulging intervertebral disc, can produce numbness, and that is a basis for either a delayed orgasm or no orgasm. If the genitals are numb, there's no pathology of the genitals, but there's a herniated disc that's irritating or damaging the nerve pathway in the spine. uh, then that, if that could be tested for and ruled out, or if it's that could be the cause,
Yeah,
and surgery can sometimes take care of that problem. So
absolutely.
it's really uh, this idea of using the pharmacotherapy is a last resort when all the other uh, possible physical pathologies are ruled out.
Got it. Yeah. So, if what is one myth about orgasm you wish everyone understood?
Well, I think maybe that people can have problems experiencing orgasm for many different reasons, and that in itself is not necessarily the be all and end all. I mean, it's possible to have a lot of uh, sexual and sensual pleasure even without experiencing an orgasm. So uh, there, it's uh, plenty of if you think of orgasm as say the peak of Mount Everest, um, it's possible to have a happy, fulfilling life if you never get to the top of Mount Everest. And so um, think of sexual and sensual pleasure as everything up to and even including the peak of Everest, but you can get a lot of pleasure not getting all the way to the top. Not
Yeah.
necessary.
Yeah. Yeah. It's kind of like the journey, right? To just
It's the
enjoy the
journey.
journey.
Yeah,
Yeah.
yeah. Um, yeah. Getting there is half the fun, or more than half the fun.
That's right. That's right. One thing that surprised you most in your decades of research?
There are two things that surprise me most. One is that the vaginal and cervical stimulation uh, has such a powerful effect, pain blocking effect, and immobilizing effect. It happen. It never fails. It just has a powerful effect. Um, and so that's one. That was the first really big surprise. Um, at least in the laboratory studies, but uh, and then of course I was pleasantly surprised that it has a similar effect in women. Um, the other big surprise was that women could feel their vagina and cervix after their spinal cord is severed,
Yeah.
and it doesn't need the spinal cord. That it's now an important thing there is that they can't feel their clitoris. They don't feel the
Mm.
clitoris because the clitoris is uh, really that the pudendal nerve that
Yeah.
carries the sensation from the clitoris that does go into the spinal cord, and that is blocked by the severed. You do need that input to feel the 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 um, the clitoral stimulation, and even part of the vaginal stimulation, because that's the pelvic nerve. Those nerves really go through the spinal cord. But the fact that they could still feel it, the upper vaginal and cervical stimulation, despite the severed spinal cord, that was a big surprise. That made that my our colleague, the spinal cord specialist, quit because she
Yeah.
couldn't believe it. She said something's wrong. I mean,
Wow.
that was a really big surprise.
Yeah.
So I think those are the two biggest surprises.
It's amazing. So, for listeners who may feel shame or confusion about their sexual response, what message would you want them to hear from someone who studied orgasm for decades?
I mean, if you put orgasm in the context of it's just another kind of orgasm, and um, do you feel embarrassed about sneezing or yawning? You could feel embarrassed. It could be embarrassing. I remember there was one of the secretaries in the dean's office um, had when she sneezed, she people came running because they thought that literally people came running because when she sneezed, she screamed
Oh my
with
God.
she "Rah!" I'm doing it quietly, but it was like she was being murdered. She let out a scream like and people literally came running down the halls to see what happened.
Oh my gosh.
So that is that was embarrassing to her. So yeah, you can be embarrassed by a sneeze in a social context, and also certainly can be embarrassed by a yawn. If you're sitting with guests and you start to yawn, that time to go. That can be embarrassing. So you can think of the embarrassment of other kinds of orgasms. So but if you can overcome the embarrassment of those kinds of orgasms, why not overcome the embarrassment of a genital stimulated orgasm? It's just another one of those.
Yeah. Yeah. I love that. I love that.
Just detoxify it.
That's right. Absolutely. Bring it out of the shame. So, for all those people listening and watching this podcast and thinking, wow, Dr. Komisaruk is so, so amazing. I'd love to get in touch. I'd love to follow more of his research. How could they? How could they follow more of what you do and get in touch with you? How could they do that?
Um, well, I think the best thing is just send me an email. I don't really do. I don't have a website or anything. I mean, I have a website, but I don't maintain it or anything. But the best thing is I pay attention to my email all the time, and it's just BRK, my initials, BRK at Rutgers.edu. And Rutgers is RUT for Thomas, G for good, ERS for Sam, .edu. So just BRK at Rutgers.edu. Send me an email, and I pay attention to my emails all day and night.
Okay. Well, thank you so much for coming on and sharing your
Good.
wisdom and your knowledge. This was such a fun podcast for me to record, and I really appreciate your time. And thank you for all the work that you've done to advance women's health. It's amazing.
It's been my pleasure,
Thank you.
literally.
Well, we are done here. It's been real and really intimate. And remember, this is not meant to be any type of medical advice. If you have any questions about your sexual health, about your orgasms, about anything, make sure you go see your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.